Next up is a virtual presentation. Increased regional market competition lowers threshold for revascularization in asymptomatic carotid artery stenosis, presented by Dr. Sorber on behalf of a joint collaboration between Johns Hopkins and University of Colorado.
Thank you for allowing me to share our research. Increased regional market competition lowers the threshold for revascularization in asymptomatic carotid artery stenosis. My name is Rebecca Sorber, and I'm a clinical PGY4 general surgery resident at the Johns Hopkins University School of Medicine. We have no relevant financial disclosures to report. The stroke prevention benefits of revascularization for asymptomatic carotid stenosis were established in a series of landmark trials completed in the 1990s. With subsequent improvements in best medical therapy, as well as the advent of transfemoral stenting and TCAR, the landscape of carotid occlusive disease management has changed significantly in the past 2 decades. Some experts now advocate for surveillance alone for all asymptomatic carotid lesions, and there are currently several major trials underway seeking to establish updated management guidelines for asymptomatic stenosis in the context of these new therapies. However, societal guidelines still consistently recommend revascularization for asymptomatic carotid lesions greater than 60%. Consequently, there is substantial controversy surrounding the contemporary management of asymptomatic carotid stenosis and variation in revascularization practices amongst proceduralists. Previous research has demonstrated that increased market competition amongst physicians can influence surgeons to behave more aggressively with respect to elective procedures. Elevated local market competition has been associated with the repair of abdominal aortic aneurysms at smaller subthreshold diameters, as well as the transplantation of lower quality renal allografts. This is thought to result from provider concern that patients in high competition areas will seek procedural intervention from other available providers, resulting in tolerance of greater risk on the behalf of the proceduralist. Given the multitude of revascularization techniques available, as well as the controversy surrounding the appropriate management of asymptomatic carotid artery stenosis, we hypothesize that local market competition may also be a driver in asymptomatic carotid stenosis revascularization practices. The aim of this study was to examine the association of regional market competition with revascularization thresholds for asymptomatic carotid stenosis. We also sought to describe the association of regional market competition with thresholds in symptomatic carotid stenosis, which in theory should not vary, as revascularization for carotid stenosis is indicated for all patients with symptomatic disease. This was a retrospective cross-sectional study utilizing data from the SVS Vascular Quality Initiative database. We included all patients undergoing first-time carotid revascularization across all modalities for carotid stenosis 50 to 99% between the years 2016 and 2020. We excluded patients with missing data on the degree of stenosis, laterality, patients with less than 50% stenosis, patients with carotid occlusion, or those undergoing carotid artery stenting as part of intracranial therapy. Patients were then stratified by symptomatology into symptomatic and asymptomatic groups, then further stratified by degree of stenosis into moderate, defined as 50 to less than 80% stenosis, and high-grade stenosis, defined as greater than or equal to 80% stenosis. Using this data, we then calculated the Herfindahl-Hirschman index in order to measure physician market competition for each US region. This value depends on the market share of each provider in a region in percentage points. The maximum HHI is 10,000, which would reflect a complete monopoly. Thus, HHI can be interpreted where higher numbers reflect lower levels of market competition and vice versa. We chose to utilize the US Health and Human Services regions as geographically meaningful regions to measure regional competition amongst physicians delivering carotid revascularization procedures in the United States. Overall, we identified 149,337 patients undergoing first-time carotid revascularization during the study period. Of these, 38% were asymptomatic. Amongst asymptomatic patients, those with moderate grade stenosis were more likely to be white and to be current or prior smokers, and were significantly less likely to be on antiplatelet therapy, though statin use was equivalent between moderate and high-grade asymptomatic patients. Asymptomatic patients as a group predominantly received endarterectomy as their revascularization method, while the approaches for symptomatic patients were much more varied. When examining competition by region, competition was overall quite high in the United States, as reflected by the relatively low upper limit of the HHI range at 370. This reflects the large number of proceduralists offering carotid revascularization in the United States. The highest competition region identified was the Great Lakes or Chicago region, and the least competitive region was the Denver or Rocky Mountain region. When examining the relationship between HHI and the revascularization threshold in asymptomatic patients, a 10-point decrease in HHI, which corresponds to increased competition amongst physicians, was associated with a small, albeit significantly increased likelihood of receiving carotid revascularization at a moderate degree of stenosis versus a high degree of stenosis. As expected, an identical analysis in symptomatic patients showed no significant association between competition and the revascularization threshold. We also examined in-hospital outcomes and found that moderate-grade asymptomatic patients had a significantly higher likelihood of stroke and stroke death following revascularization when compared to high-grade asymptomatic patients. Again, an identical analysis amongst symptomatic patients did not demonstrate this relationship, instead showing a slightly increased risk of mortality for high-grade versus moderate-grade patients with symptomatic carotid artery stenosis. This relationship between moderate-grade stenosis and composite stroke death remained significant on multivariable analysis and was significant only for asymptomatic rather than symptomatic patients. In conclusion, increased market competition is associated with the higher odds of revascularization for moderate-grade versus high-grade asymptomatic carotid artery stenosis. An identical analysis in symptomatic patients undergoing carotid revascularization demonstrated no influence of market competition on the revascularization threshold. These findings suggest that market competition may influence more aggressive behavior with respect to revascularization of asymptomatic carotid stenosis in patients who may otherwise be good candidates for surveillance. Taken in context with the small but significant increases in adverse perioperative outcomes demonstrated for moderate-grade asymptomatic patients, these results should encourage critical reflection by proceduralists about what factors motivate the decision to offer revascularizations to patients with asymptomatic stenoses less than 80%. At a minimum, there is room for improvement in ensuring that patients with asymptomatic and symptomatic carotid stenosis are in best medical therapy prior to undergoing revascularization. The results of CREST-2 and other ongoing trials designed to assess best management of asymptomatic carotid stenosis will be critical in assessing the appropriateness of these behavior trends and to direct future research in this area. Thank you, and I'm happy to take any questions.
Thanks for your excellent presentation. Reminder, as you're coming up to the mic, Dr. Coleman and I are relatively blind up here. Please introduce yourselves because we
100% blind.
Can't always see who you are.
Misty Humphreys from UC Davis.
Thank you.
I'm a little curious about this because if you think about sometimes how we operate on these or how vascular labs read duplex ultrasound, for some labs they have criteria from 60 or 50 to 69% and then greater than 70. Is it possible that some of your subjects or some of the patients that are listed in that moderate degree just couldn't have been classified as greater to 80 because their vascular lab doesn't read that criteria?
That is indeed that. So for this data set in the VQI, there are a number of different modalities that get reported. So there's CTA, there's ultrasound, there's MRI. There's a number of different things to get reported. As we reported it, I don't think that, I think that what you're describing, if it had been greater than 70, I think would have fallen into missing data. It wouldn't have fallen into the greater than 80%. I don't, and if it had been greater than 70, it depends on how it gets reported in the VQI. So that's kind of dependent on how the person who's reporting to the VQI reports it. But if they had just said greater than 70, it wouldn't have gone into the high grade category. Whoever is reporting to the VQI should not have reported something that is just greater than 70 as 70. But that is something to think about going forward, that everybody's vascular lab reports things differently. So obviously that's one of the limitations of this analysis, is that it's limited by the inputs, but I think that the VQI is probably the best resource that we have for having high quality information on stenoses, because I can't think of another large data set that would have anything near to the degree of granularity that the VQI has. But that is a good point. That is one of the limitations.
Thanks, Vic Kasher from Cleveland. Dr. Sorber, beautiful presentation. Thanks for presenting this information to us. Can you give us a little bit more detail about this index and how it actually measures competitiveness? I mean, you could have a location with a lot of board-certified vascular surgeons, but perhaps not all of them doing carotid revascularization. So how do you know that that index actually reflects market competition? And relevant to that, if I'm understanding this figure that's in the abstract book, the very lowest competition area has the highest percentage of asymptomatic carotid disease treatment. That's 44% in kind of Nebraska and the center part of the country. So how do you explain that discrepancy? And lastly, would it make more sense, even though it may be not feasible with VQI, to actually look at very specific zip codes? Like you could pick probably Manhattan and LA and Houston and a couple of other areas as very competitive regions, and pick other zip codes that are much more rural and get much more of a granular answer to this question of whether competition actually makes us more prevalent to doing operations. Thank you very much.
Thank you so much. I'm really glad that you asked this question because it speaks to a lot of things that we kind of wanted to answer when we did this project, and then it also brings up a lot of the limitations of this type of project. So your first question was about the index itself. The index is pretty simple. When you think about it, it's really just the number of providers. So in this case, it would be the number of providers that are reporting to the VQI that would measure how much competition there is amongst the people reporting to the VQI. So if the people aren't reporting to the VQI, they don't get measured in this particular index. So all the index really measures is competition amongst the people reporting to the VQI based on their state ID is how we did it. We were able to get state level data when we did this project. Then we went ahead and arranged those into regions by the HHS. We could have arranged them into any region, but that's just the one that we chose. So it's limited by who's reporting to the VQI. That is a large limitation in this because obviously there's a lot of providers out there that aren't necessarily reporting their procedures into the VQI. Another thing that you asked about, which is a great point, is when you look at the actual regions based on competition, the ones that are very low competition, or when I say very low competition, it's actually a misnomer because all of these regions have relatively high competition. But the lowest competition regions being the Rocky Mountain region and the Great Plains region, those are actually the lowest reporters. So even though they are the lowest competition, they do have a higher rate of revascularization. And it doesn't have a perfect one-to-one correlation because as we showed that impact of competition actually has a relatively low manifestation of how it actually affects revascularization rates. If you look at the work that I think Mark Schorhorn has put out out of Harvard, he has a lot of good papers, and there are a lot of good papers in Europe as well as other places in the United States that have looked at a number of large data sets and shown that there's a lot of regional differences in carotid revascularization practices that we don't fully understand. And even in this paper, I didn't show this data because I think it's too complex to talk about in such a focused, short presentation. But there are still regional differences on multivariate analysis that are specific to each region that show that you have a higher likelihood of having your moderate grade asymptomatic lesion revascularized in Colorado than you do in Illinois, for example. And I don't, this data set doesn't fully explain that, and there are a lot of factors at play. This is just one very small one that I think it's interesting to reflect on. And we asked this question, and the story kind of came together in a pretty interesting way. But it's a great point. That figure that's in the abstract booklet, it does show that. It partially has to do with the N from these low competition regions, but it also has to do with there are extant factors that are influencing people who gets offered revascularization by region that can't be explained by anything that we've teased out so far, either our group or other groups that have looked at this.
Thanks, Dr.
other-
Sorber. I think we are going to have to cut you off. We're
Okay.
over a bit. No, great answers, and I'm sure there's a lot more we can discuss with variety of people offline. Thank you so much.
Right.